Today I'll be talking to you about prostate cancer, which is the most common non-skin cancer among Canadian men, with 1 in 7 expected to be diagnosed with the disease in their lifetime. So luckily, the survival rates are excellent when the disease is caught early, but there's still much to do to improve treatment, with research now focused on reducing procedure time and improving patient quality of life. So one of the most common methods of treating cancer is radiation therapy, which is really harnessing energy to kill cancer cells. This comes in 2 main forms. External radiation means the radiation source damages the cancer cells from outside the body. This procedure takes a long time, however, at approximately 25 visits to the cancer center. This is a really large burden on the patient. Conversely, in internal radiation therapy, also known as brachytherapy, the source of radiation is actually inside the body, as shown in this CT image on the right, showing radioactive seeds that have been implanted in the prostate. One of the main draws of this technique is that it can be done in as low as 1 visit to the cancer center, which is a really great benefit to the patient. And this is the focus of my research, specifically in something known as high-dose rate brachytherapy. In this procedure, several needles are inserted into the patient's prostate, and a single very high-activity radioactive source is then inserted into the needles to deliver an even dose of radiation to the whole prostate. To help guide those needles and visualize various organs, we need a form of imaging in prostate brachytherapy, and the most widely used modality is ultrasound, specifically transrectal ultrasound, meaning the ultrasound probe is inserted in the patient's rectum. Ultrasound has several advantages over modalities like MRI and CT, especially the fact that it's real time, but it can be difficult to interpret these 2D images, and that's mainly because we're dealing with 3D anatomy. The physician has 3D needles trying to hit 3D targets in a 3D volume, all while using 2D images for guidance. This requires complex mental computation. So to address this issue, our lab has developed what is known as 3-dimensional or 3D ultrasound. This works by rotating a standard ultrasound probe and capturing 2D images along the way that can then be placed into a volume as shown on the right. This greatly elevates the usefulness of ultrasound. However, for every 3D image captured, an accurate manual segmentation of the prostate is also required. And in many cases, such as this example, poor image quality and shadowing can make it very difficult to identify the prostate boundary accurately. And that's really our clinical problem. Manual segmentation is time-consuming and it's very difficult, often taking 20 to 30 minutes during the procedure. So our objective was to develop an accurate and fast artificial intelligence method to automatically segment the prostate. So to accomplish this, we're using a specific type of artificial intelligence known as deep learning. This technology powers things like self-driving cars and is prevalent in nearly all of our software and electronic devices, from apps like Facebook to devices like your cell phone. In the simplest sense, deep learning, or a neural network, is a series of connections which help a machine learn patterns and features that allow it to do things like classify whether an input image is a car or not. So you can think of it as trying to mimic the billions of connections in a human brain. This requires a lot of training data, or examples that the network can learn from. So in our case, we trained our algorithm or network by giving it thousands of clinical ultrasound images of the prostate with corresponding manual segmentations. The network then learns patterns and features. Essentially, it's learning how to identify the prostate boundary. So we then need a method to go from these 2D segmentations to a full 3D segmentation. Our method starts with a 3D image of the prostate. Starting from the approximate center of the prostate, shown as the red dot, the 3D volume is sliced radially in equal 15-degree increments about the center of the prostate. A 2D image is extracted at each interval, and this results in 12 2D images that look something like this. These images are then passed through our neural network, which identifies the prostate boundary automatically. The 2D slices can then be put back in their place within the volume, and their boundaries can be connected, resulting in a final 3D segmentation, which looks something like this. Here are results for an example 3D segmentation on an image the algorithm had never seen before. The red contour is the manual segmentation, the blue is our proposed method, and the yellow is a state-of-the-art 3D segmentation method. We can see excellent agreement between our method and the manual segmentation, greatly outperforming the state-of-the-art method. A full 3D segmentation was achieved in less than 1 second. So this is huge savings compared to the 20 to 30 minutes it'll take for a physician to do it by hand. We also trained our algorithm on a diverse data set of images from multiple procedure types and multiple ultrasound machines, making it generalizable, which essentially means that it'll be more robust or can handle diverse clinical data, increasing the potential for translation. Bottom line is that our algorithm offers the potential to ease physician burden and reduce procedure time, increasing patient quality of life. Of course, this work wouldn't be possible without this amazing group of people and the following sources of funding. Thank you all for listening.